Test and stream. 1, 2. Test and stream. 1, 2.
by Chuck, second by Dr. P. All those in favor signify by saying aye. All those opposed by nay. Okay. Next on our agenda will be an update on our 19 annual incentive. Mr. Whitman. Good morning.
So this represents the final numbers for fiscal year 2019. We showed you some preliminary numbers at the last meeting in September. PSI 90, which is a composite of a lot of patient care, patient safety, hospital-acquired condition index. 1 is expected versus observed. It's neutral. Anything below 1 shows significant improvement. Anything above 1 shows there's room for opportunity. Everything has opportunity, but in establishing last year's goals, we thought stretch at 0.88, which is significantly below 1, was a worthy pursuit, as well as 1 being where one would expect us to be given the acuity of our patients that are cared for here. We finished the year at 0.91, somewhere between target and stretch. In terms of service, we have HCAHPS and we have an outpatient survey. HCAHPS, we elected and you approved last year to look at the dimensions of service that we provide our patients. There are 10, and we established a goal of improving each of those dimensions at the national rate of improvement as measured by press gain, as NRC picker. So each dimension had a separate rate of improvement on a national scale. Our goal was to improve each of those dimensions by that national rate of improvement or greater. So we elected and you approved that we were targeting 5 of 10 for target and 8 of 10 for stretch, and that was in relation to the national rate of improvement. We achieved 7 between target and stretch. The patient experience from the outpatient perspective was based on a series of 10 questions. And given that there was really no baseline to look at the national rate of improvement last year, this was our first effort to look at 10 separate questions. We elected to use 0.3, improvement over self. So any question that improved 0.3 or greater, we would be given credit for the improvement based on this particular metric. So we established similar performance goals of 3 for threshold, 5 for target, and 8 for stretch. And throughout the year, we were consistently better on 8 of the 10 questions, 0.3 or greater. So we did well in service, and service was weighted 35% of the total annual incentive plan. People, we established a voluntary turnover rate. This is just total. So in the first year, this is total turnover. Last year, we finished the year at 13.06. We made some improved performance goals from that. Unfortunately, we were not able to hit last year's results at 13.06. We came in at 13.35 for the fiscal year ending September 30th. Employee engagement, provider engagement. You're going to hear a presentation from Pia later on in this meeting. NRC Picker helped us, or, I'm sorry, this is Press Ganey. I keep going back and forth. Press Ganey, the vendor, helped us establish the performance goals last year based on where we finished September 30th of 18. And that baseline was 4.37. It was top decile performance. Press Ganey helped us establish these thresholds, target, and stretch for fiscal year 19, knowing that there might be a little bit of slippage since we were top decile performer. We came in at 4.33, which was a little bit above target, and Pia is going to go over the results of that later, as I said. Provider engagement. We have a special focus on that this year, as you know. 3.89 was our baseline in fiscal year 19. We established those performance levels, as you see there, and we actually hit 4.02 for the year ending September 30th. Stewardship, we have two goals. One for executives and above, VPs and above, one for the rest of the organization, VPs below the level of VP. Modified cost per adjusted admission is for the organization as a whole, not including the executives. And we were fortunate to hit 12.965, which exceeded stretch for fiscal year 19. And I think the financial results that each of you've seen during the finance meetings and the board meetings reflect that.
Can I ask you a question?
Sure.
I guess this is my stupidity. Why do you want the modified cost per admission to go up as the target
You don't.
instead of down?
It is intended to go down. You mean for last year's results, the baseline?
The modified cost per adjusted.
The baseline was 12,799 last year. Every year is different. It depends on the budget, right?
Okay.
So each and every year stands on its own. It's not reflective of how you did the previous year. It's whatever the budget is for that given year, then these different performance levels are established based on the budget.
Okay. I think.
Okay.
Chuck, I believe the first year we did this, we thought, well, that might be a little tight. And then, so they moved it up. But this is the second year we've done that, so we need to relook at that because that is a concern that, I know where you're going, the threshold is so much more than where we ended. But we'll talk about that.
Okay.
The new ones in the new budget.
And for VPs and above, we established a performance goal of net operating margin. We came in at 0.1% in fiscal year 18 and established 0.25, 0.66, and 0.85 for fiscal year 19. And as you know, the financial performance was exceptionally beneficial to the organization in fiscal year 19. Finished the year at 2.96 operating margin. So that's the goal for the non-physician executives. And let me throw a wrinkle into this. As we began to evaluate this particular plan in relation to the physician executives who serve on this leadership team, we were advised and made aware of a potential Stark violation in regard to incentivizing physicians from a volume or a monetary perspective. So we are recommending to delete the stewardship pillar for physician executives and reweight those remaining goals as you see in front of you. Have them focus on quality, service, and people, but absolutely no pillar around stewardship. And if we do that, obviously the same results are there with different weightings, and then that would equate to whatever potential payout might inure to those individuals.
Say that one more time, I missed something in that translation.
Stark violation.
Okay, and what part of the Stark violation are we? I mean,
Go right ahead.
yeah,
Well,
Just
it's
walking in.
complicated and it's changing. The old world, when Stark came about, right? And this is for Medicare patients primarily. There is a prohibition to incentivize or reward physicians based on financial performance. It could very well affect how care is delivered. That's the perspective, right? There is prohibition in incentivizing or compensating physicians around increasing volumes, driving business to an organization that physicians have some sort of a stake in. So on the advice of counsel, we evaluated that and elected to take the most conservative position possible. And if a physician executive has privileges, that doesn't mean they necessarily admit patients, but could potentially care for patients, we're recommending removing the stewardship pillar from their incentive plan for both the LTIP, and we'll get to that in a minute, and the annual incentive plan.
Let me tell you another one that was thrown out there for a while back, maybe it's still there, is you could not have free parking for the doctors that brought patients to your hospital. Correct. You had to pay for it.
Same thing. You can't provide routine food. Anything above a certain level is going to be frowned upon, is going to be looked upon as incentivizing physicians.
So any doctor that's on the administrative staff
Correct.
is precluded from any of the, I just kind of want to think about that a minute and get a little bit more information on, because, I mean, they are, I do understand the rules on the start. I just think that if you are incentivizing them for quality, how can we do that then? I mean,
For quality?
Well,
That's their job.
That's easy.
well, isn't part of making sure we meet our objectives part of their job too?
They are, but I think the difference is, and I'll weigh in here nervously because I only drove by a law school, I never went to one, is, yeah, on a bike. The challenge is if you are a physician administrator and you're dealing with financial goals, there is the belief from legal counsel that that can be interpreted as incentivizing them to get more patients or change the patient flow because they're going to get a financial benefit. From a quality standpoint, those are standards by which care is given, not necessarily a financial benefit for them. So what I'm happy to have you and other members of the board do is have a presentation by legal counsel. We're being advised by counsel. This is not an idea that we said, let's do this. We don't want to get into trouble and have a Stark violation based on their interpretation.
Okay. Well, Steve, in your other hospitals, is they excluded? I mean,
Yeah, this came up, gosh, was it 2 years ago now, or maybe 3 years ago when I first started listening when they were talking about.
Steve, why don't you come up where you've got a mic so that if anybody's listening on live streaming, they can hear your wisdom. And also, we'll put you behind a microphone where the
You don't
world
need a
can hear you.
microphone for that. I was just saying that, I think it was about maybe 2 or 3 years ago, we were talking about the incentive plan design, and that's when I heard that I think at that time there was either 1 or 2 physicians that were operating here as senior executive leaders. And so that's when I started to talk to Robert and Bill and Pia about Stark Law, and subsequent to that, they've gone to someone who has some legal standing, which is not me. I also drove past the law school quickly. And so they've gone ahead and got actual legal counsel on the issue. But absolutely, any of our clients in the healthcare space where they've got senior executives that are having clinical responsibility for patients, we do the same thing. So,
Steve, let me help by saying, or ask the question, it's not just your physicians in the organization, it's the ones that are empowered to be part of the administrative side of your health network that is the Stark Law violation. It's not any physician in the organization that has privileges, it's ones that are part of the administration making those policy decisions.
part of the leadership team.
Yes.
Right.
whether they're doing clinical or not?
No, if they don't see patients or have any clinical accountability,
Then-
Then-
Okay,
We have,
That was one of my
we
questions.
have doctors
okay.
in LTIPs
Yeah,
with,
no.
you know, EBITDA and all kinds of earnings measures and
Right.
stuff like that. It's when they're practicing.
When they're practicing doctors, that's the difference. Oh, okay.
Parkland go around the CEO?
You couldn't hear you, DT.
How does Parkland go around?
Hit that mic.
It is on.
Yeah.
Oh, it is.
Well,
Okay.
pull it closer.
Hit it again, and, no, I'm just kidding.
Because that CEO is the
Is
physician.
an MD?
Uh-huh.
Yeah, well, that's, I mean, one of our bigger clients is UC Health in Cincinnati. It's a gigantic institution, and their CEO is a physician as well. In their case, he doesn't see any patients or have any, like, clinical responsibilities in that way. I don't know about the individual at Parkland, whether that CEO, does he still have?
I don't think Dr. Cerise sees patients. I think he is a physician by training, but I don't think he actually sees patients in a clinic setting, and I think that's part of the difference.
Because Ron used to.
Yes, Dr. Anderson did, and continued to see patients.
Well, and don't forget, you can be the CEO and see patients. It's just that you can't be in an incentive plan where you have the opportunity to earn more money by driving cases into the organization or a number of activities. So you can still do it, you just can't get paid that way.
And Pastor Emerson, before your question for Amanda, and maybe even Steve, I think, Steve, you've met him in Zim. Steve serves as our executive in Pearl Meyer that has helped us develop this long-term and annual incentive program for us. And Pearl Meyer is one of an incredibly respected firm. They had another firm at JPS before. We went out for RFP, looked at those kind of things, tried to figure out the best firm to bring in. And Steve's been affiliated with JPS for how many years now? Six?
Yeah.
Four. About five. Because he
Five,
wasn't
for
here the
sure.
first year I was on.
4, 5, or 6, and it's target, stretch, in how we view him. So he's been with us for a length of time that creates some level of credibility. But
5 years.
Steve is talented and helpful for us, but Pearl Meyer and its database is hugely helpful for us in that regard.
Now, my other question now, what did it have to do with our weights? I'm trying to understand what will we change on that?
Well, we had 15% for stewardship,
Okay,
so one has to reallocate 15% among the remaining pillars to come up to 100%.
so,
It's that they don't want to diminish their incentive opportunity. They want to keep the same amount of opportunity, but they have to spread it around differently because you have one less pillar to put weight in. So you got to take that 15% that was for stewardship and reallocate it across the rest of them. That's really all they did. And they-
so
and I-
let me
and I
make
helped them.
sure I'm understanding. So you're wanting to eliminate stewardship from the pillars?
That's the recommendation.
For
For physician
physician
Executives.
executives.
who are credentialed
That are credentialed,
for this
okay.
medical staff.
But you still have the operating margin trigger, right? The plan isn't active without it?
I'm totally confused because I still believe that the operating margin should be a part of our stewardship. If we need to move the physicians off of it and come up with something else for them, then I can see that, but I don't see us removing.
That's what the recommendation is.
Yeah, we're not removing it,
We're
it's
not
just for the
taking
physicians.
stewardship out
Okay.
from, it's just for physician
Just for
executives.
the physicians, that we need to figure out for those where they're 15.
That 15% was reallocated to mainly service weight.
Yes, ma'am, and let me,
I wouldn't put it there.
well, we can put it, and that's okay, but let me define to you that it is only physicians, it's only physicians that have administrative responsibility, and it's only physicians that are credentialed here who have clinic time. So you just took your world and reduced it significantly to a very small percentage of the
Okay.
physicians
All
that we
right.
have.
3
Okay.
to be exact,
All right,
3.
3 physician
Right.
executives.
okay, all right.
And that weight reallocation was spread among the pillars: quality, people, and service.
Yeah, if I was gonna throw it anywhere, I'd throw it on quality, since that would be my primary, since that's one very. Well, I'm thinking you ought to put 10 to
Position was
quality.
provider engagement. We thought there was significant opportunity for them to weigh in and be responsible and accountable for provider engagement. There is significant physician engagement and input required for service from both an HCAP perspective and an outpatient perspective. That's why we elected to recommend that we equally spread those weights.
I'll just make a quick comment. In the world of healthcare, in executive incentives, you definitely will see HCAPs and patient experience metrics more tied in with physicians than patient safety and adverse events. That's because there's literature out there that says that doctors have a huge influence on how the patient feels about their treatment and whether they come back or recommend it to somebody else or whatever. Whereas the safety and the adverse events tends to be people that are clinical people who are nurses and care people in the hospital, care people in the clinics, tend to be the ones where that's where those issues would occur more than so with the doctor. I've got several other clients, I would say that the weighting would be more aligned with service than quality if it's a physician.
Well, since the physicians heavily influence your quality, I would see that quality is one of those key indicators for me, since they are directing the care. And if you want your HCAPs and all those to go up, if I don't get good care, they ain't going up either. So that's where I am with quality. They play a major role in it. I can see part of it going to quality. I would put the largest percentage to quality and the other to service.
We, Bill, you identified that there's 3 individuals. They were formerly under the old process. Before we're just now taking out the stewardship on them.
That's correct.
So they.
Last year, right.
Okay. So they are aware of that we're going to do that, or that's now proposed today?
It's proposed today. 2 of those 3 are aware.
Okay.
It's a fact. It's a proposal. It is a conservative proposal, but stark is a fact. Although it's changing, and they're going to revisit the guidelines again this year to attempt to move into the modern world, right? But the law's the law today.
Okay, I asked that because I was concerned on what, if the possibility, is that going to be a negative or positive impact from them to us?
We've run the calculations from a financial perspective, and it's pretty similar to what they would have been entitled to under the old plan.
Should we spread it over quality and people? And just move that whole thing to quality? To service?
If you don't mind, I think to me there's like a semantic issue with quality. I would say, yeah, the word quality, I would think of doctors. But am I wrong, or aren't your patient safety and adverse events, those are like events that occur in the hospital?
Hospital-acquired conditions and safety events, falls, CAUTI, CLABSI, yes.
So I think I would stay with what I said, that I think it's your care, a lot of your care professionals that have more of an impact on that than the physicians themselves. But it's just an opinion.
Anyone else have any?
I guess, just following up on you, Dorothy, in any business I've ever been in or been around, quality is the most important thing that you have to measure. If your quality of your product isn't there, then everything else is going to suffer. And I think that's what Dorothy was trying to say, is it just looks a little funny that quality is the least important of all of the things that you've got there.
For me, quality and people will drive your service. Service is a result of quality and people.
If you've got a terrible product.
Yeah. Quality comes back at us through Leapfrog. All of those deals tie in together. So I still believe that quality should have a higher component of it. I'm not opposed to adding something to service, but when we get down to the service, when we're talking about the future ones, I think we need to really look at that. Okay?
The reason that quality has the weighting that it does is totally derived from the weight that quality was given last year for the overall organizational annual incentive plan. So quality didn't have as high a weight last year than service did. So therefore, the allocation increased everything equally, but still quality came back lower than what you might find people or service.
Dorothy,
Yes, Jim.
one of the reasons I'm okay with the service weight is HCAHPS and patient experience can actually be tied to quality. That they're an integral part.
But these are not physicians, these are physicians that are in leadership. Don't
Right.
forget that.
Right.
They have people that they manage. It's just not, they're not doing the quality work themselves. I mean, they sit on, chair certain meeting and all that stuff, but they still have other function as an executive of the organization. That's what I'm trying to get back to.
I look at this as just, it's sort of tying it to the rest of the employees, it's just different weighting.
Well, I think one of the reason I'm having a little concern about service is this is the third year we're changing how we're looking at them. The measurement that we started with one year, we changed, and now the recommendations are we're gonna be doing a little bit different. So I wanna drill down in service. I think service is important, but I think quality is just as important as service. So that is one of the reasons that if I'm gonna do anything, I would like to see quality have 35 too, for that, if, we'll move it around. That, I mean, I got 15 to play with, I'll take 10 there and 5 at service. I mean, I'm not taking anything away from service, because I do believe service is important, but I also think that we really need to drill down and look at service and make sure that what we are measuring, we can see it going from one year to the next year, and right now, I can't do that.
So should we do 30, 35, 35? 30, yeah, 30, 35, 35.
Okay.
Is it possible?
So you're, you know,
You're saying put 10 there.
I feel like I'm in an auction. So your bid is, no, but, what your suggestion is that quality be 30 and service stay at
35. Is that
at
stay the
35?
same? And then people, 35?
35,
I'm just looking at this compared to the
sure,
regular people,
sure,
regular executives.
All right,
I understand. Okay,
okay,
Regular executives on the other page.
I understand.
okay.
35 and 30.
Oh, it's 35.
30, 35.
Top one is 30.
30, 35, and 35. So your quality goal is gonna be 30, your service is gonna be 35, your people is 35, and your stewardship stays at 15. How do you feel about that, my dear?
I'm okay. There's no stewardship for those
There's
three
no stewardship
positions.
for
Right.
the
Yeah.
physician, executive.
It would be nice that now that we've broken out those percentages, for someone to explain what we all understand quality, service, and people is.
Okay.
We might all have a different definition of what that is.
Okay. We can definitely provide those, and we will.
Okay. All right, any other questions on that?
Yeah, if you can come up with a single definition of quality, I would love to hear it.
Areas that we can see, that, you know.
Yeah, the tangible side
Right,
of it.
right, right. Okay. I think when you look at that, the PSI and see what they're measuring, you'll see some quality there. You also see some of it in Leapfrog, and so, on the service one,
But we can
we can do that.
We'll
We can show
provide
you
it.
the
We'll
10
provide it in
dimensions on
one-
that, okay?
one paper.
All right. Any other questions on that? Okay.
Okay, moving along to the long-term incentive plan.
I think toward the
This is for
end.
the organization fiscal year 19.
Hold on, just a minute.
Do we need to vote to change these percentages as it goes forward?
These are updates from staff. You guys are giving recommendations. They can make those changes and come back to you with their recommendation. This is not requiring committee action.
Okay. All right.
Okay.
We'll do as legal said, so not required at the committee level, but when we go, we'll make those adjustments. These are recommendations from us. We heard y'all, and we'll incorporate those in.
take it to the HR, are you saying we need to take it to full board?
To full board, so,
You can take
Well,
it
we're acting as a full board.
You're acting
We've
as a
got
full board.
6
Okay.
here.
so you don't need any motion to have those incorporated
We
in?
can't.
You will need a motion, but we don't, right now, you've got an update that's not requiring
Right.
committee action.
Okay,
All right.
super.
They're gonna have to come back to you with it as a recommendation.
So what
Okay.
do we do?
You don't need a motion now. It will come back in its formal form, and those numbers will be
Thank you.
as
Okay.
suggested. You just don't need a motion right now.
Okay.
Right.
Long-term incentive plan. These are the same goals we established last year, leapfrog and cost per adjusted patient admission. You can see the results for leapfrog that came out in November this month. Fiscal year 19 was 2.9028. And that's a little bit shy of what we finished up the fall of 2018. So we did not hit threshold, target, or stretch on that particular goal. This is worth 50% of the overall leapfrog, the overall LTIP metric. The reasons for that, quite frankly, we were unable to take full credit for the barcode medication administration improvement that leapfrog scores based on the fact that our Epic upgrade occurred in November. So had it occurred earlier, again, based on timing, we would have probably given credit for that. We had some slippage on Caudy and Clabsy, and have put some action plans in place to address that. PSI 90 was not factored in spite of the fact that we're doing really well. There's a lag measurement issue with PSI 90, and Leapfrog determines when they include PSI 90 and when they don't. We also have some improvement along colon SSI, and Leapfrog has not yet adjusted that improvement for JPS. We hope by the spring, when that comes out in April, that PSI 90, Caudy Clabsy, colon SSI, and certainly the barcode administration will be taken into consideration given the Epic upgrade that just occurred. Cost per adjusted patient admission. This is the reciprocal of what we just discussed in the AIP. The organization is focused on cost per adjusted patient admission. The VPs and above are focused on margin for AIP. For the LTIP, the executives are focused on cost per adjusted patient admission. We talked about that somewhat last year. And that's the same result you just saw on the annual plan, 12,965. It's a little bit higher than where we finished the baseline last year. So with a zero result for 50% of this incentive plan for Leapfrog and a 200% result for the financial performance, this results in 100% potential payout. Given don't have the slide for the physicians. Okay, same thing applies to the physicians, right? There is 50% of this overall plan focused on quality, and that quality is represented by the Leapfrog proxy. What I am not proposing to you today is the other metric that would replace the stewardship portion of the long-term incentive for those three, and depending on how many more physician executives are ever added to this organization, as long as this organization wants to take that position, that credentialed physician executives will not be incentivized for volume or financial gain. So I don't have a metric for those three physicians today, but this HR committee meets again in January, and we'll bring back a metric, a recommended metric that's more suitable for those three physician executives.
Anyone have any more questions of Bill? Okay. Thank you, Bill.
Thank you.
Tia, you're up for.
morning.
Good morning.
All right, so first presentation that I have for you all this morning is our final update for the Human Resources dashboard. Of course, this is our dashboard that we provide to you each quarter to let you know how we are performing on our human capital. As you can see, the quarter from July to September, which was our fourth quarter. As Bill mentioned to you earlier, we did not meet that goal, which ended at 13.35 for voluntary turnover. But as you can see for the quarter, looking at the total turnover and total involuntary turnover, we have provided those metrics for you to see as well. Just to let you know, again, for those of you that are new to the board, when we are looking at these benchmark numbers, we are benchmarking against Saratoga data. And Saratoga provides what the benchmark needs to be at for that total turnover. So just wanted to provide this information to you all to let you see how we ended the year, and also this provides an overview too by job class of how we're performing for that voluntary turnover. Are there any questions?
I do have.
Okay.
I may be looking at it and I don't recognize it. But at the last meeting, Trent Petty wanted to have the tenure, I mean, the people that have been here less than 3 years on the executive group, what the turnover was for that.
Yep, and we were gonna bring, since he brought that up, we're gonna bring that to full board. And I know, realizing this is a full board, but when we sort of rescheduled things, I wanted to make sure that everybody got that. So we'll probably send that out and then discuss it at full board.
Okay.
Okay, are there any other questions on it?
And I would, that's probably a juxtaposition, find time to thank you all for understanding that when we switched AM to PM, and we had the meeting scheduled for 11:30 PM. We did not call any of you to ask if you wanted to do that. However, I do want to divulge that you had a board chair, a committee chair who's willing to meet at that time. But we, to 2 members, but we suggested that maybe we didn't, so that's why we changed the meetings instead of having it at 11:30 PM on Thursday night. You wanted popcorn and a Coke and everything else. Breakfast too. So.
Okay. Do anyone have any questions on this dashboard from here?
Okay, thank you. So next, what we have for you is the updates for the 2019 Employee Engagement Survey. Just a couple items before we do jump into the presentation is that the Employee and Position Engagement Survey were both taken September 9th through September 23rd. The participation rate for the engagement survey was 92%, which was 5,520 participants for the survey. So just wanted to make you aware of that before we do jump into the presentation. So the first slide, what this does is provide you with a model of the workforce engagement. As we think about employee engagement, when you do look at that, what makes up a high engaged workforce is the organizational domain, the manager domain, and the employee domain. When all that comes together, what it does, it provides an overall organizational score of how an organization is performing. Some of the key elements when we do look at the high performance organization is the quality, the patient experience, financials, and then the organization culture as well. And so a lot of times we do get questions from leadership, and as we continue to educate our leadership and our workforce, we provide this workforce engagement model to let you know how that score is delivered and how we make up that score for the organization. So let's jump into the employee results. As you can see, we have provided to you all history here, looking at the engagement results. This provides the data from 2013 up until 19. For 17 and 18, we were scored at top decile organization, and also for 19, we did do very well at the 89th percentile. And working closely with Press Ganey, that top decile is something that's very difficult for an organization to maintain. But for JPS, we did score very well at the 89th percentile. Some of the things that we do want to focus on for our areas of celebration is from our team members is that they truly enjoy the work that they do. They feel as though JPS does contribute back to the community, and they feel that JPS, from a diversity standpoint, values all employees from different backgrounds. Where we look at opportunities for improvement is more of having them involved in decisions that affect their work, satisfaction or recognition for doing a great job, and then also the biggest component from a leadership standpoint is a climate of trust. And that goes to both leadership and the team as well. Next, what is provided to you is trending data.
Pia?
You have a question?
I'm sorry.
For the last one, the climate of trust,
Uh-huh.
is that a time that you would suggest to work toward that?
Do we need to work towards that? Yes, because trust.
Timeline, like, is it gonna, I know organization is very hard to do. Is that 18 months, 24 months,
Well,
26 months?
every year for our leaders, they are required to do action planning. And so it's going to be something that we as an organization, from an overall organization standpoint, is thinking about how do we help to improve that score. And so because we scored at the 89th percentile, we did not score extremely low. It's just an opportunity for improvement. It stands out from the other scores that's something that we need to continue to focus on. So each year from an organization standpoint, we have to think about how do we continue to focus on that question. And then for those departments of where it scored lower than their norm, it's looking at them to think about how do they build that trust with their teams and their leaders as well.
One or two or three common themes of pinpoint to help out in that?
Well, I think that, you know, as we look at FY20 and we looking at that first year turnover, one thing to focus on is when team members are onboarded into their departments, how do they trust their leaders and how do they build relationships? It's communication, and that communication is two-way communication with leaders and their employees. And then also, being transparent and giving open feedback relating to their performance and not catching someone off guard. And so a recommendation that we always give to leadership is that if an employee is having performance issues, don't wait until their performance appraisal to give that feedback. That needs to be something that's done on a consistent basis for that team member to give you, for that leader to give that feedback to build that trust.
Could be tough to fix because of the turnover is a little bit higher than that.
Well, think about it. It's going back, it's going back to that turnover, and think about Saratoga State's 11.2. We're at 13.35. And so the key thing for any team member coming into an organization, and I always put myself in the shoes of the employee, is the trust. And so trust is the biggest thing that we have to focus on. How do we build that two-way communication between the leader and the employee for them to trust each other, to help decrease that turnover, but then also to improve in the score too as well. Yeah. Does that answer your question? Okay.
Pia, can you repeat again how many respondents there were?
Yes, so there were, let me go back to my notes. So we had 5,520 participants that were respondents, and 5,974 were invited.
Thank you.
That's a huge percentage.
Okay. So going to this slide here, it provides engagement trending data, and this is just to give you an overview of how we have trended with the national healthcare average. As you can see in looking at this here is that when you look at other like organizations similar to JPS, where they are scoring with the national healthcare average as well.
Any questions?
So in working very closely with Press Ganey, who has been our vendor throughout the timeframe of when we have done engagement surveys with JPS, they did make a couple of changes to their terminology for the year, and I wanted to share this all with you. Usually in the past, what has occurred, we have rated the departments tier 1, 2, and 3. We set their keyword tier. But now, Press Ganey has changed that information to team index, where when we think about a score being determined, it's both an effort of the leadership and the team members to work together to be able to arrive at that score. So Press Ganey took feedback from their customers and thought about, what is the best way and the most possible way for everyone to understand when it comes to engagement. It is about the leader, but it's about the team too as well, helping to arrive at this score also. So this is a change that has occurred for 2019.
Could you refresh my memory? What are some power items?
Yeah, so the power items are the questions, and I don't have those in front of me, but I can provide those to you of what key questions are the power item questions that drive the survey score. So next what you have is the JPS team index distribution. This provides to you all the distribution of the team index 1, 2, and 3. As you can see, the gray is from 2018, and then those that are colored differently is for 2019. And what the team index score, it just tells you from a team index perspective of how our score is looking different for the year for 2019. One of the most important things that we do like to look at is when we look at that team index 3. From 2018, we had 4%, and we did rise up a little bit at 10% for 2019. And those are the groups that we work very closely with, HR and the leader, to do rollout to ensure that the team members are still willing to work with us to help improve their scores.
It may help you all to understand that through questioning, through the performance of the team and the department, that team index 1 is your high-performing teams. Team 2 or team index 2 are those that might have minor challenges. They may have a retention rate that's up. They may have some other challenges. They may have had more people leave that area. And then team 3 or team index 3 are those that find they have the most challenges. They have leadership issues. They may have had quite a few of their leadership team come in and out of that division. So we watch those closely. What Pia has done, which I think is smart, is she's taken the Team 1 index and paired them with Team 3's. So if you've got a division that has some challenges, we're going to try to pair them together to make sure that they're getting all the right things. So I think sometimes we forget that y'all don't see these numbers all the time. I want to explain to you sort of where those teams are in the high-performing teams. But that 10% that is in the Team Index 3, those are not terrible performing teams. Those are teams that just have some indications that we have some challenges in those departments, and they're sort of on the watch list, and we try to help them. We try to figure those out. And we do seminars and symposiums. We pair them. And we have found the most effective, Pia and her team, and have found the most effective is when you have peer-to-peer kind of discussions. When a manager of this department says, this is what I did in my department to create levels of engagement, recognition, those kind of things.
I find it interesting that the improvement or the increase in Index 3 is almost the same as the decrease in Index 1.
In Index 1, that's right.
So they lost some of their strength in Index 1 because they were working down.
Mm-hmm. It could have been, there could have been a variety of reasons, and we'll look at that. Last year, we had a slight increase in Team Index 2. The numbers stayed 3, varied a little bit, and 2 changed more. This year, Team 1 changed slightly down to a Tier 3. So or a Team 3, could get my vernacular right. There were tiers last year, there are teams this year.
Yeah.
So that just kind of gives you an idea of how we watch the performance. And where the organization was lacking 8 years ago and some of the changes we made, we weren't able to go down through individual departments. We looked at the organization in its totality, but we didn't go down to the department level. That's why this is so important. It really goes down to the department level and gets an analysis. Sorry, Pia.
I think the next one is.
So as we communicate to you about the team index, also one other key score that is very important as well is the readiness score. So what occurs is that they also get that team index score, which is that 1, 2, or 3, but also what occurs is that they also get a readiness score. So to help you understand how this works is that, for example, if a department is a team index 3, more than likely what will occur, they will have a low readiness score that sits right here in the third box. And what that readiness score defines to us is that team willing to work with that leader? And that's a time of win for us when we see those scores. That's where we determine from an HR perspective and an organizational development perspective as well, is that we need to work very closely with that leader to do the rollout. And then HR and organizational development works closely with those teams to help with that rollout, but then also do a discussion on a start, stop, and continue method to find out what they can do to help improve that score as well. So we have 2 core pieces we have to look at. We have to look at the team index, and then we have to look at the readiness score too as well. Are there any questions?
Any questions? Okay.
So the leader index, we did score moderately high, looking at 87. Looking back at the slide that I provided to you, this gives us the score. And what makes up that score is the questions that are above it. The person I report to treats me with respect. I respect the abilities of the person to whom I report. The person I report to encourages teamwork. About their job satisfaction, communication, as we talked about, which is key to any department, and then being involved in decisions that affect their work as well. So as an organization as a whole, our team members are still willing to work with us to action plan. And so that's why for us, we do the department action planning, but HR works very closely as well in delivering and doing a organization action plan too as well.
Pia, when individuals answer those questions or address those questions, is all of that anonymous?
Yeah, everything is anonymous. No one has access to that data but Press Ganey. So HR, no one on the executive team has access to see how that's rated, yes.
It'd be interesting then how to find out how to address that then, because if there's one person to encourage teamwork, if there's somebody who's lacking in that, how do we get to that?
Pinpoint it.
Yeah.
And so it goes back to the question that DT stated earlier, is that when we look at department action plans, if that is something of where they score low, because each department, regardless if they're a team index 1, 2, or 3, everyone is expected to action plan. And so if that is an item of where they score low and it drove down their action planning, then the expectation is for them to work around that. But again, it gets back to the big overall organization. When we look at the organization, what skills or what tools can we put in place to help with that question on the communication and how they're involved in decisions that affect their work.
But wouldn't you be able to identify, not the individual, but the department that scored low in that?
We can.
So, because it's broken down by units, so.
Right, it's by units, not by person, because we can't see that information. Again, this is a confidential survey, and the thing is, it goes from department to department. So when we look at common themes, we can see departments out there where these action items score low.
Okay. Okay, as I'm looking at this, I see this as bottom up as opposed to top down. The person who addressing these questions here or making comments to those questions are the subordinates speaking in reference to the supervisor.
Yeah, leader. It's a
Okay.
leader index score. Yes, sir.
Okay. I guess I'm trying to figure out how do I identify, or how do we, okay, so let me back up. So that says that a department, the leadership level of that department or unit will be shown as a unit, the score that it was.
Yes. And remember, this is the entire organization. So this is organization. The organization as a whole is markedly high at 87. So this is our entire organization. But what has occurred, each leader, if they receive a report, if they have 5 or more direct reports, they receive a score, and they will have the ability to see their score, and their accountability and their responsibility is to action plan around their items, around their top low-scoring items.
Okay.
And we tell them to focus on at least 3 to 5 items that they want to focus on for the year. Yes.
Any other questions on that?
So this provides to you, just as in our previous slide, this is the JPS Leader Index Score. And so this gives you an overview of the departments, of how they score. And as you can see below, it provides the high, moderately high, moderate, and moderately low. And so this just gives you a snapshot of those departments with their scores. So when we look at JPS versus the national healthcare average, as you can see, these are the top items where JPS scored well. Again, this just provides an overview. And even though we came in at the 89th percentile, we still performed well, but these were the highest performing items where we scored well from a national healthcare average. So just wanted to give you an overview of this, of those items. One of the key things that, for myself, that I like to look at is question number 41, which is a key indicator, is I feel like I belong at JPS Health Network, which is very important because for our team members to have a connection, for us to continue to have high employee engagement, our employees have to feel that they have a connection to the workforce, and that they also to serve the purpose as well. And because we have a workforce that is over 50% millennial, that is something that's very important for our millennials to feel that they have a connection to the workforce. So many times we hear just from case studies and from SHRM is that our millennials are wanting to be the president and CEO of an organization. Well, that's not true. They're wanting to have a connection to their work and have a clear understanding of that work as well.
Have you seen a difference between, on this particular question, between full-time and part-time employees?
Do I see a difference? Have I seen? Now, when I drilled down into the data, it's scoring the same because the key thing is that when you're looking at the full-time and part-time, there's not really a difference. I think where you may see a difference is between the full-time and the PRNs, because the PRNs are here probably least, and sometimes, you know, with a leader having that interaction, it may be a decrease for them. Yeah.
Now, I will tell you, between this page and the next page, as a leader here, there are parts of this survey that will literally drive you nuts, and it will make you pull your hair out, because in many of these, we're way above national averages. But yet, you see a slight decline, and it's very slight, with the number of people who say information from the survey will be used to make improvements. But yet that's one of the greatest strengths we have too, that most of the organization sees this survey as the greatest tool they have to make improvements. And I think we've shown that. And PIA does a good job, along with communications, of telling people what we heard from the survey and actions that we took to deal with those. So you can look at the declines, and they're important to know because it may be trend setting, but at the same time, all of the declines still put us above national averages in most of the cases. I don't know, Pia, of any one where we're below a national average, even on the declines. So we try to put things in perspective, and sometimes we get things that could be interpreted differently. I feel like I belong at JPS, but yet sometimes there's a trust factor. So you have to juxtapose those to try to figure out what you do. Now, the ones that say my pay is not equal to what others make, or my pay is lower, maybe y'all have worked, maybe you, Zim, have past experiences from employees saying my pay is way over what I thought I would ever receive, and the benefits are greater than ever, but I've not seen those organizations anywhere. And so that's always a concern. That's always, I think where PIA's stance on that is, let's make sure that everybody knows what benefits are available to them, so no benefits are left on the table.
Before you go further, the last column to the right, that example, that 0.04, is that the decrease?
Anything in the red is the actual decrease. That column that's in your very right, the AHA, that number there is like organizations that's in our region as well. So that's just right here in this actual region. So that is a different number, and that is new this year with Press Ganey, but the key number that we like to look at is that national healthcare average. And so even though, just like Robert stated, is that when you go back to the previous slide where we had the greatest improvements, and those were some of our biggest accomplishments, when we look at the survey and we scored well at the 89th percentile, these were some of the lowest scoring items on the survey.
Okay, so okay, the plus 0.04 says on a national healthcare average, our employees are satisfied with their benefits, +4?
Well, no, what it is that this was a decline. So from 2018, what occurred, these questions here were a decline from the previous year. So from the previous year of 2018 to 2019, we saw a decline in these questions. That's what occurred.
So address what the national healthcare average, what that plus 0.4 means for Pastor Emerson.
So the plus 0.04 from a national healthcare average, what occurs when you see that plus, that means that there was improvement, but it declined from 2018. So in 2018, we did a lot of benefits communication for our team members, but what occurred is that we had a change in our healthcare of introducing a new premium to them. And so what occurred is that this year in 2019, when we had something new that was rolled out to the workforce, what it is, we are still having to get in front of them to get them to believe that that is still a great benefit. And that's just an example. So that's what occurred. So
but actually, I'm sorry, that's not asked that because I was going to, that was going to be my next question. Didn't we change the benefit plan?
We did.
So that's why you see that.
Yeah,
But
we did.
and help me, because I'm not trying to put words in your mouth, and they may be the wrong words, so correct me. Even the decline that we saw at JPS from one survey to the next, in all of these categories still puts us above the national average.
It does.
For the, if you took this same survey, there would be lower attitude at another facility about their benefits than what our employees feel about their benefits at JPS.
Right.
Is that
No,
a
you're
fair
right.
statement?
Yeah, very
I'm
fair
not trying to give pluses to JPS.
No.
If we've got one that's a -10, we need to look at it. I just want y'all to have perspective that we just took the lowest ranking in a good survey to focus on. those still compare higher than any of the national averages.
Yes, that's correct.
Yeah, but that also mean that we did have some changes in our benefits, and the employee
Yes.
is saying, I'm not happy with that.
That's
So,
right.
and they went down on that.
I agree, and I'm not trying to glaze over that. We're still, and again, those are always challenges, particularly when you add new benefits or change benefits.
Okay.
I had one comment, if I may.
Yes.
This slide is the first time that I've noticed there's even green or red on here.
Really? Well, good for you.
Just the two.
How come you can see that and I can't? What happened to your eyes? It's all those carrots.
You're not as good as I am.
Thank you very much, I can tell.
All right.
So let me understand, this is a standard survey that goes to like hospitals all over the nation, right? Okay, because I'm not a fan of surveys.
Right.
In general, surveys either do one or two things to an employee. They provide them with a sense of expectation or a sense of feelings that they have of disappointment with the organization. And it's real hard till you get very specific in your survey questions to do a whole lot. So my point being, how do you make improvements in this that you know what you did caused that or not, except for maybe benefit plans?
Yeah, a couple things. First of all, I think one of the signs, the first preliminary sign that JPS would be into trouble is to see a significant decline in the number of people that take the survey.
And you had about half of your employees take it this time?
No.
92%. 92%.
Ninety,
Real unusual.
it is. It is unusual, and it's unusual for organizations when I go out and meet with them. I've not met anybody who's at 92. And I think if you saw it go from 92 to 82 to 72, that would be a significant sign, no matter what their answers are. I've always made the point, if they're willing to take the survey and communicate, they've got investment in JPS. Even if their comments are negative, they still care about wanting to see changes. The other thing is, in those tiers, in those teams, Team 1, Team 2, and Team 3, you would begin to see those numbers change from higher levels of 2s and 3s because there's been dissatisfaction and they feel they're not getting anything. So some of it can be empirical and some of it's anecdotal and what you see as the changes. But I still think the biggest factor is, can we keep our numbers at 89, 91, and 92%, which is hard to keep every year. And then we have a series of town hall meetings and information that is follow-up to this to figure out, what do you want? What did the survey tell us? What do you think? And we have a really good response from people physically coming to a town hall meeting as well. So I'm not a huge survey. I like you, I agree with the points you made, but I think here the survey does have some impact.
And I agree, when you've got a response of 90%, then that may be not requiring empirical data. It may just give you a good across-the-board toast. I know at General Dynamics, we did this one year, and probably 35% of the employees responded. And they were pretty honest in their response. So what we did was, instead of listening to their responses, we opened up what we call a country store so that Dad could pick up a quart of milk before he went home to his family. The next time, the survey was almost non-existent because we didn't address their significant issues in any manner, shape, or form. Another thing we did was, there was a question about ergonomical chairs. So without asking, they went in and gave everybody a different chair. And about 50% of the people said, I like my whole chair. So it's how you respond.
That's how you respond. I agree.
Any other comments? All right.
Some milk when I get home.
There you go.
Next, what we want to do is just give you just an overview of the provider engagement survey as well. Again, the provider and employee engagement surveys are administered during the same time frame. This provides to you the organizational summary and review. Key things to look at for the provider survey is that They did have great participation this year, and they did reach a score of 4.02. With the physician engagement survey, they have two core pieces, and that is alignment to the organization and then resilience. And then resilience was the first year in 2019 that was implemented into the survey. So we do have two different key pieces relating to the physician survey as well. But this is just to give you an overview to let you know their score. They did have a great year with their survey and did meet that engagement score as well.
I have another question.
Yes.
What is the definition of the resilience index, decompression, and activation? I had no idea what those.
So what occurs is that with resilience index, what that occurs from a Press-Ganey standpoint, I'm going to quote it to you in Press-Ganey terms, is that is basically a physician's connection to the organization. How much are they willing to work with the organization? How do they see their connection? And do they feel valued? And how do they have the ability through change to be able to stay connected to that organization? And so that is in the terms of Press-Ganey.
Yeah, what is decompression and what's activation?
Well, decompression for them, what that looks at is how well does that physician connect to the organization, and then activation, how much are they willing to change to the culture of the organization. So we think about JPS. JPS is an organization and workforce that constantly changes. So how willing are they willing to stay connected and willing to change with that organization as well?
I still don't understand what decompression and activation mean.
That was the piece that activation is for them willing to continue to stay with the change of the organization, and then decompression, basically how much are they willing to stay cultivated and stay connected to the workforce as well.
Dr. Weber, these are not behavioral health terms, because you think a lot of times in terms of resilience as a behavioral health term, in terms of how resilient are you in terms of stress and your coping. And decompression is something that you do to go home and meditate and be calm. And activation would be, do you get excited and are you ready to go to work? They're similar. The activation is, do the physicians want to engage with this hospital? 4.55, highly. In terms of decompression, are they willing to stay through this process? And we are above the national average with this particular score. So, and they call that resilience, because I think when you think organizationally, you need to have that solid physician base that's resilient to change within the organization. Does make sense? So that, and so that's, yeah, I probably wouldn't have used those terms myself, but.
Yes.
I don't think they give you an
No,
opportunity.
you did a great
to-
job, yes. So that's it.
This is addresses physicians.
This is physicians, yes.
Okay. So does this correlate with a claim?
All physicians.
So the rank, the 39th is 39th. We rank 39th out of 100 or 39th overall?
Overall for the physician engagement survey. So the score that we look at, just like how we look at the employee score, as you can see from 17 to 18 of where they scored the 31st to the 24th. And so they met their score this year where they scored at the 39th percentile overall for physician engagement.
Yeah, because I noticed that we went up, and that's what I was asking about. I was wondering how a claim, all we went through at the beginning of putting a claim together, how that impacted what this chart did.
Yep, so this is all physicians, yes, sir.
The improvement in that score is pretty substantial, because we all went through the changes in the claim and the challenges, and this is wrong, and why are we doing this? You now see that starting to not only level out, but now you're starting to see it increase, which is a really good sign. And I will tell you that if a claim has ever changed 20 or 30 years down the line, they will be as mad at that as they were at the beginning of this. It's just nature.
It's just nature.
It is nature.
Any other questions?
All right, and the final slide for the provider survey, just as we provided to you for the employees, is the areas of celebration. As you can see, they feel that their work is meaningful, that they see every patient as an individual person with specific needs, and they all care about their patients equally when it's difficult. Areas for opportunity. Overall, I believe my patients feel highly satisfied with the care they receive from JPS. Overall, I'm satisfied with the performance of laboratory services, and JPS is appropriately staffed to provide high-quality care to patients. So these are their areas for celebration and areas for opportunities when we do look at the provider results. Just for the employees and the physicians, to make you all aware, the accountability and expectation that has been set for both is that now it's a time of where the data is being executed to the employees and to the physicians. And then what will occur is that everyone is required to action plan, and all action plans are due to the Press Ganey portal by December 31st. And then throughout the calendar year, we ask that everyone in their department meetings to look at their survey data, review it, provide feedback, and give updates on how they're making improvements due to those action plans. And so that is next steps.
Okay.
Are there any questions?
All right.
Okay, thank you.
Sharon, you're down for a benefit update, but I need to do that in closed session. Okay, all right. All right, so then, Bill, you're back up.
Okay, this portion of the meeting is devoted to the proposed annual incentive plan metrics for fiscal year 2020 that we're currently in. Under quality, we're recommending that we continue with PSI 90. This is something similar to that you saw in the September meeting. We've now got performance goals in this one based on where we ended the year. We ended the year 0.91. We're recommending threshold is 1, which is observed versus expected. It's neutral. Target is improved over that, and stretch is the same stretch we had this year. Under service.
Could I stop you on that one? I'm looking at that, and we ended up with 0.91. So we are expecting that we would go up 0.09.
No, we want to go down.
Well, but we have a target to go up. That's what I'm saying. And so one of my questions is when I go back and look at that, we're at 91, and then our target is 0.95. We don't expect that we're gonna, I just find that those numbers going that way, to me, we should look at reevaluating that. I think sometime we set those where we've gone 0.09, and then the next one is 0.05. So we don't, I know it's hard to move, but I don't think that we need to set our threshold that we're gonna go up 0.08, 0.09.
Well, once again, this is based on the philosophy of 90% achievable, 50% achievable, and 10% achievable.
Well, I think we ought to put it at more
And
practical.
this is statistically significant improvement over the 1.0, which is observed expected.
Well, point being, even if it is .0, is statistically sound. I don't think it's statistically sound for us to go back .08. That's what I'm saying. To me, that's how I read that. This is what we resulted, and my threshold says, okay, we're gonna go up to 1.0. So, I mean, I just have problems with that. I can see you saying on that one, maybe, Dorothy, we might not stay at .91. Maybe I'll go to .95, but I can't see me saying we going .08. That's your biggest jump of all.
I think said another way, the whole purpose of your goals is to provide an incentive for your employees to do better. And it says, don't worry about this one, we don't expect you to do better, and this one is the more general message that I see from it.
I agree with you. That's what I see. And so I was thinking that if you wanted to, I know you can have some slippage. I know people, I don't expect slippage, but it happens. But I don't think we ought to give credit for it. So I was looking at that threshold being, I'll give you a little slippage, .95, but then I was gonna do your target at point, I hadn't figured that one out. But
Well, I would say if you're going to do something that maybe the target is .90, which says you're going to do a little bit of improvement over 19.
okay.
And your stretch could say at .88, but I'm not, I didn't go by a law school, and I didn't pass my statistical test either, so.
You didn't pass that. I understand.
It's really a perception is what.
Right.
I think we're talking about here, Robert.
I understand.
Since those two just confused me. Explain to me the 0.88 from the 0.95. Let me back up. This past fiscal year, we were at .91.
Correct.
And we want to, our goal is to at least get to 1.0.
That's neutral, so to speak.
That's neutral, no.
Right?
You want to get under that.
And that's,
You want to go down.
that's an observed expected rate based on your patient population
Gotcha.
and the acuity, right?
Okay, gotcha. All right.
So we want to stay at least there.
Oh, okay, I got you, okay.
And based on the philosophy of 90% achievable, that's why we recommended that 1 is the threshold.
Okay.
Well,
got it.
I'm with Zim. I just don't expect it to go up. I mean,
You may expect it to go up, but
that's not the message you want to send, right?
Okay. Well, I mean, staff is going to follow the will and appreciate the comments of board members. So if board members would like to see this at that level, we will make it that, and we will make those goals.
Well, I would pose the question to you differently. I don't think it's what we want to see, it's what you want to see. And do you want to see it go to .95?
Well, I don't want, your point
No.
and Dorothy's point are well taken. And then if we've got a perception issue, you don't want that. I don't want the community or others saying, is JPS being rewarded for something that doesn't look like they've accomplished the goals or the goal they need to accomplish?
To be fair, is there any new line of service that we've added that may cause it to go up because we got more complex cases?
Could. This is a 10 composite metric, right? And any one of those could present a variation. And like finance and budget, each year stands on itself, depending on the population of patients that you serve.
Well, I don't think we ought to look at it, that might be one of those. Even if it does go up, it should not be like you expecting it to go up. When I see that we have numbers, I'm here, and then I look at your paper, it says to me, well, we're not really expecting to do better. So I'm gonna go ahead and put it out here. And I don't think my 10 and 20% and stretch 100% is the answer. Is that it is to improve the service. And I think the perception of what you're saying, when you look at it, I would see that we've got the .91, then we got .90, then I got .889, and then I got your .88. I mean, I just think you need to look at it that way. They're not a lot, and you say statistically it means something, so I think those numbers can, I mean, I was gonna shift your stretch a little bit lower, but you didn't make it last year, so I'll leave it there. But in between where you are and going to stretch, it needs to be this way, not this way, and then that.
So your numbers are, again, what do you see threshold?
I think I would go with them on .9. I mean, you just see a great, I got 1, then I got .89, then I got .88. I mean, they're tight. That's one of the reasons keeping your stretch at 88 was tight to me.
The threshold can stay at 1. I mean, that's just the baseline.
It is, that's.
Open the doors, so I don't have a problem with that.
The challenge is that when we look at some of the numbers that Michael presented last week, and the patients get sicker, and that will drive that
It would,
number.
it would.
So we kind of in a interesting transition period where you're flipping from CMI, and then just look at the population, and then you transplant them to get to that point. I can argue either way.
So let me try to help out board members here. Your comment is threshold could actually stay at 1 point,
Yeah, it's,
but the key number here is target, and the target goes to a .89, and then you keep stretch at .88.
What was our target last year?
You don't want it to stay at 1. You want that to change.
That's your largest increase, is your .8. If you're saying you're at .91, to get to that 1, you're saying I'm going up a .8. Supposedly, each one of those little .1s and .2s are statistically important. Then I can't see you saying the biggest area you're given is that one, the .8 right there. That says, okay, from where we are, we can go up .08. I have a problem with that. I mean, I'll go back to my .94, but it's just, to me, you're saying on that one it's .09. That is the biggest increase you show out this whole scale. Even getting to stretch from where you are only .07, so.
So your proposal for, again, your proposal for change is .90, .89, and .88. That's where you would want it.
I will go back and give a little over here. .994. I mean, I'm willing to, it's hard for me, I tell you, because that to me says, you're saying, I'm looking for this to go up, even though, and I don't like to see that, but then I could do the .89, but then I want to change the .88 to .86. I mean,
Dorothy, when I look at the historical, in FY18, we had a 1.1, and last year we set the threshold at 1.2. We set the target at 1.0 with a stretch of .88, and we had a .9. And so the target this last year was 1.0. And here we have the target at 0.95. Does that help a little bit with how those numbers are flowing across, that we started with 1.1 in FY '18. FY '19, our threshold was 1.2, not 1.0. So we're actually lowering the threshold by 0.2 in this proposal. The target was 1.0 last year. Our target is 0.95 this year. So we're actually moving in that direction of improvement.
Well, if .91 is what you did last year, and you're targeting .95 this year, I don't think that's moving towards improvement. It may be improvement towards improvement from a threshold standpoint from last year, but it's not, doesn't have anything to do with the real metrics that you've been working towards. If there's a reason, that you need to go to that you decided to go to .95, except some statistical measurement, then okay. But the other part of me that says, well, if my quality is going up, then why isn't service people and stewardship going up at the same time?
I hear you. I feel you. I mean, I just think that is one of those points that when you look at it and you see those numbers going that opposite way, I'm not comparing what I said last year. That was the first time we had those. We said, okay, this was good. I thought, okay, this is the first time we used them. Let's look at them. But then you did better. And now we want to set it where we go up, oh, then we come down. So I don't see it that way.
Well, I guess where I'm confused now is because the target last year was 1.0. The target here is 0.95.
But you actually got to .091.
But our performance was better, yes.
But you actually, result was .091.
Right.
So when you say it to me like that, it says, okay, we did better, but now I need to go back to last year so I can start planning again. I don't see it that way. We improved, and I don't want to schedule.
Well, our threshold was 1.2 last year. It's 1.0 now.
I don't want to compare, Dr. P, I don't want to compare what my threshold I set last year to what I actually, for this year, since I actually did so much better than my threshold. Does that?
Sure.
And so, because I set it at one last year, I should go back this year and say, oh, that was a good threshold. I don't see it that way. Help me. And I just have that, and we can discuss some others, but I'm still uncomfortable with us having numbers that show our results of this, and then it shows, when you look at the paper, we are going up. I'm sorry.
I'll just say it one more time, and I know I've said it before. Please know, each year stands on its own. The patients that we serve are different, and anything below 1 is considered pretty darn good.
I'm still going, I'll go back with your threshold at, which one, 0.94. I mean, I just hear me say this. If you were, that's hard for me to see we did this well, then I want to see it on paper that I'm going up 0.08. I just hear me say that. That's hard for me to deal with. Now, I don't know what my numbers should be, but I don't think it ought to go up no 0.8, the largest increase that you have here from where you are is that one.
Well, Bill, what information do you have that you use to say this is going to be 0.95 this fiscal year?
The concept of the incentive program as structured by Pearl Meyer is based on a threshold of 90% achievement, target of 50% achievement, and stretch 10% achievement. And that's what we tried to line up in regard to our actual performance of fiscal year 19.
So, no, I'm sorry, Zim, did you
Go
have a
ahead.
response to that? Okay. So if, because we do our metrics all the time, so we always try to hit stretch, no matter what, if that's possible.
Well, you don't bother to call.
Based on this as an incentive plan, what is the incentive for hitting stretch then? Is it a higher percentage?
It's a higher percentage.
Higher percentage.
I think it's worth twice the value of target.
Mhm.
This whole program is worth, for managers and above, 10% of base compensation.
Okay.
And this is a plan that everybody in the organization participates in. So managers, below manager, the incentive award based on performance is up to $500.
And so in the past couple of years, have y'all hit stretch or have y'all hit target?
It varies each and every year. This year was a very good year, very good year. We've not done this well historically. And I've said this to Dorothy many times. This is not science. There's a lot of art to this, right? You're trying to balance a lot of variables. But the concept of the plan is 90% achievable, 50% achievable, 10%. And that's what we try to do.
But
And use statistics in coming forward with recommendations based on performance.
Yeah.
So-
Let me see if I can say it this way. It's a 4 or 5 year plan. And some years, usually the first year you pick up low hanging fruit. And then you're gonna have to go back to reality. It may jump up again and then go back down. So that, I think we need to look at where do we start in 2018, what's our target, and then improve from there. And then the result is, it is what it is. But sometimes you pick up low hanging fruit, sometimes, but you can't just go here and then go down, down. You just can't. It statistically won't get you there. Is that the correct way of looking at it?
Well,
Yes, sir.
unlike Dorothy, I don't want to set just arbitrary numbers. So if this is what the staff feels is the right numbers, I'll go with that. I'll just tell you that there's a perception there that is something that I see as an issue.
If we table this and bring it back for the January board meeting, what degree of challenge does that put us in?
None?
Well, most of the goals, with the exception of population health, which are new, we talked about that at the September meeting, is coming back with population health specific metric. Most of these goals have been cascaded anyway. They haven't gotten the performance expectations because they hadn't been approved by this committee or the board. So the goals, quality service, people, stewardship, are well known throughout the organization. Population health's new. So that's the only one that we have yet to introduce. If we want to take a respite and bring back performance measures in January, can certainly do that.
I think once we see the result for 2017, 18, and overlay to 19, you can see it's improving. And then the goal, the threshold is much higher than what we see here. That's why I've seen your side of it too.
It begins very, very different. You know, the better you do, the harder it is to sustain or show improvement. It's just a fact.
I guess the question I have, though, aside from what the organization has had, what degree of jeopardy or confusion does this put the organization in if we do this in January? Or we come back in December and have an HR committee meeting? What I don't want to do is, I want to respect the views that y'all have, because there's logical argument to that. I get it. I also want to make sure that we're picking the right numbers, that 0.94 or 0.90 is the right number, and it's correct, best we can.
And I kind of want to say that I will not pick numbers that says that we're supposed to be improving care, and I'm going to pick numbers that says 90% of the time, you're gonna get this. I'm not. It's supposed to be based on our results. So the numbers we set up, I don't think I have to set up my threshold, because it should be based on us getting better.
And I kind of am with DT on this one. I can argue both sides of it, just as a statistician.
And you took stat classes.
I did.
There you go,
I
and
did.
you
I took
passed
it.
them.
We're gonna leave that alone. No, I did pass that. No, but also human nature. I mean, I think that you do have a stretch goal of 0.88 here. And if they have a double incentive to reach those stretch goals or to reach those target goals, I'm not the target necessarily, but the stretch goal, I think people are gonna strive to do that either way, and that brings up your quality, that brings up everything else as well in doing it. I mean, I understand what you're saying here about we don't want a perception of backslide, but I think that also there's some flexibility with understanding the statistics of the 90, 50, and the 10.
I think if you look at from the result,
Mhm.
when you had a perception, if you look at the 3 years
Yeah.
goal setting, you do see improvement quite a bit
Mhm.
from that, and it's coming down quite a bit too. So it's just where you anchor and look at it. Because the result for me is doesn't show much for me, because it can be low hanging fruit, it can be trial and error and stuff like that. It's the consistency of how you set the goal low and low every year. That's what matters to me, and I think that's what you guys are trying to do also as well.
Correct.
Was the adverse events list the same in 2020 as it was in 2019, or was anything changed?
For PSI 90, they're the same. So, back to your question. The action plans are not going to change. I mean,
Right,
regardless of what the number is,
right.
we're going to do as best we can to meet the goal of improved patient care, right? The only thing that I would suggest, if that's the direction that we're going to pursue, is that we visit the population health goals. So if this committee approves the goals in general, not necessarily the performance targets, but the goals, then we can cascade those and begin working on them.
Okay, I'm good with that. But let me just say that on your service agreements, let me just say it now. That's a third party giving us the reports on that. Is that not true?
NRC picker.
Okay, so could we get some of those reports the same way we're getting when we do the provider? Because I would like to see where we are on those 10 matrix so we could actually set something.
I'm prepared to share that with the committee today if you would like to see that.
Yeah.
They've been, I think, there was a sheet that was on the board portal, but Laura Burnside is prepared to come up and provide that report to this committee.
Well, if we weren't
I
gonna.
know you've asked that before, and I think this
Yeah.
committee needs to know that. We're very proud of the results.
Can I try to explain this one more time?
Yeah, go ahead.
Last year, we set at 1.1, right?
That's correct.
Oh,
18 was
1.2.
1.1.
1.1, and they're trying to hit the 0.8 something on the stretch. They didn't get there, so they end up at 0.91. So if we use that as the threshold and force them to go further, it's going to be very, very tough, because they was trying to shoot for 0.88 or 0.87 or whatever that is. They didn't quite get there. But that doesn't mean we use that to penalize them going forward. So that's how I look at it from that perspective.
Okay.
I hear what you're saying, DT, and I'm also saying that, again, it is very difficult for me to see improvement, and then, you know, you don't bring me but 1 year. I know what it was, because you just started this, and you're going this way. You want it to go down under 0.0, under 0.1, under 1.0. So it's hard for me to sit here and say that, oh, your results was 0.91, and, oh, yeah, we're going for 88. But in between, I'm going up before I get to 88, okay? It's just difficult.
Well, here's what I would suggest to y'all as committee members. Let's go back and make sure that y'all are comfortable with a population health goal. That's different.
Okay.
If we can have that and we can leave the meeting with that, we have the initiatives to our employees to start working on these goals.
Okay.
We will then come back to you all at a either December meeting or a January meeting of HR, depending on when you as chair want it, and we can move forward with that. So if we could come out and know what that population health goal at least
Okay.
is, and y'all feel comfortable with it, then my suggestion is to have Laura Burnside come up on those service and go through that, which is upon your request,
Okay.
and get an idea of what that is. And then I think we feel fairly good because we can have the input that y'all gave us all the way around the table. There's been different input. And then we will meet with you, Madam Chair, and go over those numbers. So,
Just, I'm with that, just one question. On the stretch, the 0.88, do we have down, or have we talked to employees to determine what we have to do to get to 0.88?
Yes, sir. Yes, sir. We have action plans developed that will enable us to hit .88 or lower. But as I said, each year stands on its own.
This is all we have to do to go to 88 from where we are now. That
Right,
is-
so if we had 0.82, the action plan would be different than the action plan for the
I
0.
don't think they would. I think the
That's
action plans that we have in place today are going to enable us to do as best we can for the patients that we're serving. There's nothing that's a secret sauce, so to
Right.
speak, to get improved results.
Okay.
It's basic blocking and tackling.
We'll table this and bring it back, okay? Now, I'm ready for HCAP.
For population health?
Well, no, we're gonna go ahead and finish on some of the plans, but we're gonna, on the quality ones, we're gonna bring it back.
and then you want to hear about, you want Laura to present here, and then we discuss population health?
We can do population health, because that's new. The rest
Yeah.
of
It's
this
new.
we
That
can
would be
get back to.
great. Yeah,
Okay.
if we can do that,
Let's just do population
that would
health.
help our team a
Perfect.
lot.
Okay.
We had an extensive discussion about population health in the September meeting. We had proposed an ED throughput goal, which I recall there was significant concern about us shooting ourselves in the foot because there's only so much improvement you can realize from an ED that has only 56, now 69
Right.
treatment rooms. We pull it off the table, and we focused on population health, which is where everybody in the world is moving. But everybody in the world has perhaps a different definition of population health. So we are of the opinion, we don't necessarily have all the mechanisms in place, the measurement mechanisms, to really focus on true outcome improvements. That's coming. But we've identified two areas that we want to propose your consideration. One is a focus on diabetic population. We have around 10,000 diabetic patients in our connection population. And we admit a lot of type 1 and type 2 diabetic patients that probably don't need to be admitted. So what we'd like, and don't focus on the performance targets, just focus on the goal. What we would like to do is to create a goal around decreasing the type 1 and type 2 diabetic patient admissions connection population for 2020. Those connection patients that have diabetes with short-term and long-term complications, those patients that have uncontrolled diabetes without complications, and those connection patients that have diabetes with lower leg amputation. We want to focus on getting those patients treated outside of the hospital, connecting them with primary care physicians, patient-centered medical homes, and decrease the number of admissions for those specific patients in the year 2020.
Okay, let me get this. We're going to be looking at decreasing that 10,000 number of...
Decreasing the admissions for type 1 and type 2 diabetic patients with those conditions that I just enumerated versus 2019. lowering the number of patients that were admitted to the hospital,
Okay.
okay? And there is a composite. It's based on the admissions per 100,000, and that's what we'd be focusing on. Not the number, the pure numbers, but the composite on the rate per 100,000. And we'll come back with specific performance goals the next time we meet.
So let me make sure I understand that we're going to be looking at the percentage based on 100,000, the calculation is based out there on 100,000 diabetics.
It's our rate per 100,000.
Your rate per
Yeah.
100,000.
So our
And how many
baseline,
have we identified that we have?
Pardon?
10,000?
How many have we
How many
identified?
have we identified? Because are these going to be JPS connection
oh
where
yes,
you have?
it's pure JPS connection.
Okay, well, you ain't got but 42,000 of them, so I'm trying to.
10,000 of them have diabetes.
Okay, and I'm just trying to calculate that 100,000, how that
The
ties
number
would
of
tie in.
admissions, right, is somewhere around 250 per year from that population based on these conditions. And we want to decrease that as much as we possibly can. So to do that, you've got to focus care on all 10,000 because you don't know who's going to be admitted.
I got that
So
one.
that's the true improvement. And I wish there were a way to measure the improvement for all the other patients that aren't admitted, but this is a proxy. If we do it right, we'll decrease the admissions, but think about the improved care that we can provide for the other 10,000 patients.
I'm very happy with the
Okay.
the goal, monitoring the diabetics.
Right.
I'm just kind of trying to understand the overall number that I'm going to be dealing with is 10,000, and their average admission per 100,000 is 250 a year, right? Is that what?
Somewhere in there, if we were to hit stretch, what we're currently proposing, and I'm not recommending that we
right.
focus on that, but we'd see a decrease of 52 admissions. That's not a lot, but think about the 10,000 that we're having to better manage to decrease 52 admissions a year.
Right, well, that was my thought. We was dealing with 10,000.
That's the real improvement.
Okay. And I think it's a good, I think, I don't have any problem with the measurement. I think for population health, focusing in on diabetes is a good start.
Okay.
I'm just wanting to make sure that what we are setting up, it will be meaningful
Sure.
for our 10,000. Because right now, I know, I looked at Sharon's information, I saw how many JPS connections were coming in. I didn't have any diabetes numbers, but I'm really glad that we're getting that because I will be able to know that number. And then you're telling me that of those 10,000, we're gonna look at reducing admissions by 52.
And
That's
what
the
that
stretch.
Exactly, and what that 52 means is overall improvement to a system that is very, very challenging population because you're changing their lifestyle. Now, Amanda, Zim, and Steve Montgomery and others have expressed to me an interest in population health. And Amanda, this is very much what we talked about when we had the first meeting, Pastor, and that is, first of all, population health is the biggest buzzword in American healthcare. It was the buzzword that was called ACOs 8 years ago, and everybody had an ACO in their garden, and it was a unicorn. And so everybody's talking about this. My approach for JPS is to focus on key components of population health. If you start biting this thing too big, you will lose. We will do nothing. We will waste money, and it won't be effective. The other thing is changing people's attitudes towards life and the way they eat and the way they do things is going to cost this organization money in order to save this organization money and hopes. So to me, this is a strong goal, and it is an attempt to deal with our most problematic population that we've got, diabetic patients.
Well, yeah.
Can we carve out the diabetes associated with pregnancy, gestational diabetes? Because if we start looking at that and blending in, we
Exclude that.
Exclude diabetes related to pregnancy.
Because otherwise, we're
Diabetes
not going
1
to
and
provide
2.
care for the right population that they need it. You know?
It's meant for diabetes 1 and diabetes 2.
In
gestational diabetes is something, it's not a diabetes 1 or 2, unless they already have diabetes 1.
But I just want to make sure that we don't include that.
We haven't in these numbers yet. It does not include that.
Okay, all right.
Okay, Amanda, you had a question?
No, I was making clarification.
Okay, you had a question?
Sorry, not so much a question, but a comment. In order to reach and achieve those goals, it's going to mean doing some joint programs outside of JPS.
Correct, and it's going to mean that there's got to be a lot of collaboration and cooperation within JPS, from the acclaim provider side, from the community clinic side, from the access center side. It requires a lot of coordinated effort. You're absolutely right.
Not only that, Pastor, what you're going to is it means a community effort. This has some parallel, and I hate to say it, but it has some parallel with infant mortality. But the key for JPS, I think at this point, is if we can show change in a diabetic patient with connection, something we can control, it's my hope to be able to take that to our community partners, not only within healthcare, but in our churches and in our community centers, and say, these are the things that made changes in the diabetic patient. What can you be doing? Because we already have a model at JPS, and I believe that's changing their nutritional ways. The challenge we have with JPS, and I don't want to get too much on a pulpit here, no disrespect. I don't want to just what I don't want to do is give an oration, because what I'm passionate about this, because the challenge is people come in for episodic care. And they come in when they no longer can see or they can't walk, and we are dealing with amputations and blindness way downstream. Right. But to get them to change that and not come in and think JPS is the answer with a pill or with surgery, we got to change them eating the worst of food and doing the worst of things to their body when genetically they're predisposed to having challenges. And so we add to their problems. If we could change their nutrition intake, we could change their lifestyle, then the medications JPS could give would be a proponent, not an action to an amputation or a blindness.
Yeah, because when you go back, Commissioner Brooks has his annual prostate cancer. Right. Okay, then maybe we need to look and talk to Commissioner Brooks of having
an awareness of yes, very much an awareness of what you do.
He does Alzheimer's also, so to look at.
I agree.
Okay.
This one get us closer to social determinant of health and all that stuff.
Yeah.
Yeah, it does.
I agree.
I think
Right at the seat of it.
we're all in agreement that that's a good one. We'll get some more information as we
Sure.
decide to set standards. Okay, and what's the second one?
We have staff that feels very strongly about linking some of our connection population to primary care. So 1,600 times a month, we have connection patients with ambulatory care sensitive conditions. And there's 7 conditions that qualify as an ambulatory care sensitive condition: asthma, angina, COPD, diabetes, grand mal seizure, hypertension, and heart failure. Those are called ambulatory care sensitive conditions. In other words, they can be treated in an outpatient setting. So upwards of 1,600 times a month, some of these folks come into the ED with these conditions, and they don't have primary care physicians. They're not impaneled in a medical home or with a primary care physician. What we would like to do is to increase the numbers of these patients that have primary care physicians and at least one visit. So when you look back historically, you'll see that the patients that came to the ED perhaps did have a primary care physician and did have one visit. We know exactly how many of those patients today are impaneled and have had at least one visit in the last 12 months. What we want to do is look at the patients that have one of these 7 conditions or multiple 7 conditions and make sure they have a primary care physician and they visit that primary care physician during the 12 months. That's the recommendation.
Well, I'm kind of thinking about the outcome of what you're saying. We have a JPS connection. They've been assigned a primary care provider, right? And now we're wanting to see if they came to the ER, did they have one visit, right, with their doctor? Is
Well,
that kind of what you're saying?
The one visit per 12, in the 12-month period of time is to validate, not only do they have a primary care physician, but they actually visited that primary care. It's not enough just to assign a primary care physician to a patient. We've got to ensure and work and facilitate
Totally agree.
that patient visit with a primary care physician.
Totally agree, but I would look at it a little bit different than basing it on the coming into the ER. You now know how many patients, we have a JPS connection, they've been assigned a provider, so would it not be best for us to look at the actual number of those folks that are actually seeing a doctor, getting a wellness visit, than just...
Well, we want to keep these folks out of the ED, right? And we know what that population looks like that has one of those 7 ambulatory care sensitive conditions. We know that. We know that. What we want to do is to increase the numbers of those patients that are impaneled with a primary care physician and actually visit that primary care physician. That will keep them out of the ED.
Well, what if you find out that they are already seeing their doctor and still coming into the ER? Just let me kind of finish that thought. What if you look at it based on Sharon's data? Love it. She said how many folks were going into their primary care, how many visits they was actually being seen. So I'm not sure that we won't find that some of them have had that one visit. My concern is, what are we doing at that one visit?
I can't answer that. What I want to focus on, what this focuses on, are those that don't have a primary care physician and aren't going to the doctor. They're coming to the ED.
Well, okay, let me try it another way. When Sharon provided us data on JPS connection, 90% of them were already in our system. Now, what I don't know, if in the last 2 years, oh, I thought it was a year, okay. I'm just having some problems with that outcome, okay? And how would that compare us to other clinics and stuff? How would we be able to have a standard that we should be looking at? Is there any way that we have some?
I don't know what comparative benchmark is out there. It's based on impaneling as many of those patients as you possibly can.
Well,
We know the ones that aren't impaneled have higher ED visits. We know that.
I beg to differ on knowing something on the primary care doctors that have been assigned a panel. They do have information on how many of those are being seen and how many of those are getting visits. Now, they also probably have some data on how many of those, because they're working hard for their primary care patient not to go to the ER, they're going to urgent care center. So I'm just trying to figure out a more tighter measurement, because we already know they go into the ER. Maybe you could bring some data back showing of those coming in, how many of those have never seen their primary care doctor. I just kind of,
well,
this one is kind of.
We have those numbers, and that's what we're trying to improve. We're trying to decrease the visits to the ED and increase the number of those patients that have primary care visits and a primary care physician.
So how many patients do we have?
Pardon?
How many patients, unduplicated patients, do you have going to the ER? And how many of those have not seen a primary care doctor?
We have 1,674 patients that have one or more of those ambulatory care sensitive conditions, right? 1,154 have seen a primary care physician in the last 12 months. So we've got a potential gap of, call it 480, that don't have any relationship to a primary care physician and haven't seen one. So we're trying to increase that number and decrease the ED visit.
Is it too, is it too hard to track the quality measure and then let's just pick the top? No, there's probably about 40 something that people are looking at commonly. But let's just roll out the top 10 for this year, next 10, and the following year, and do based on the quality measures. That way you can look at the numerator and the denominator, and then you can see where you are on that. Would that work? Because that
Well,
does come with, you can
I
look at
thought that's
diabetic,
kind
you
of
can
what
look
we
at-
tried to do, because we're currently at, on a 12-month rolling average, we're at 69.46% of those patients that have a primary care physician and have been to that primary care physician in the 12-month period. So 30% have no relationship.
No relationship at all.
And that's what we want to focus on, is that 30%
With these 7,
with one of those 7 chronic conditions. It's not perfect. It's not the outcome that we're focused on, that we really need to bring forward, but it's kind of a step in the, getting your feet wet, right? It's a step in the right direction. It's not the perfect metric, but it begins to position this organization to do things greater than the future.
Address your rising risk and your high utilizers.
Right.
And if you can begin to do that,
That's why when you look at the quality measure, then you can look at certain quality, the one that you want to do to gain traction. And then that will hit the rising risk and all that stuff at
Right.
the same time.
right, to me, this is the beginning of doing this. Next year, when we come to y'all, if we can get this in place now, I think you'll see even more sophistication with this, but I think you have to start somewhere. And we can poke at it for a variety of ways, but I think you've got to almost with this one start, and you're starting with the smartest population by where your rising risk and your high utilizers are.
Right. Because I'm trying to think a little bit differently, because when you start getting ready to sign those value-based contracts, they're going to ask you to do certain quality measure reporting at the end of the year, right? Certain condition, diabetic, all that stuff. So we probably already have that, but if we can do those things, it makes it a lot easier for us to start looking at how do we decrease the span when you look at utilization, all that stuff also as well. So it's kind of encompass all in one at the same time rather than just one cut at a time. So.
Okay, are there any other questions on it? I mean, I'm for, let's move on, and then once I see the data, then we can address it. I mean, that's kind of what you're saying. We're going to start somewhere.
And you all feel comfortable, it's a feeling from this committee right now, that again, I'm trying to tell y'all what y'all are thinking, I never do that. Because sometimes I don't know it. But what I want to do is I want to make sure that you all are fairly comfortable with population health, so we can at least roll that out and get that moving with our team and let them know we have a population health goal.
I think I'm comfortable with us looking at population health. And I think one of the keys to me is how patients utilize their primary care doctors. And I think that's critical. That addresses a whole bunch of ER visits and everything else, so.
Yeah, I'm comfortable as long as we can define that, because that will help you with avoidable ED visit and all that stuff.
You bet.
It will.
Okay. We just want to get that sense so that we didn't make a wrong step.
Okay.
I just hope we all agree on the definitions.
Right. I agree.
Well, just to make your day, there are a lot of people that think that population health is not the term that ought to be used, so.
We'll get a new one.
Yeah.
I was at a conference and I asked that
The
question.
industry can't get set on a buzzword alone, but we will, and we can do that, I think. I think we will be a bit of a trailblazer in some of this area.
It's no different than the old HMO, PPO. They call it differently.
I agree. Okay.
The other issue was the physician executive, but it's the same issue we talked about in 2019. We can bring those metrics back again. This is not including stewardship. And these are definitions of the 2020 plan. The LTIP, we're proposing to use the same metrics leapfrog in cost per adjusted admission for everyone except the non-physician executives. And then, as I said before, would bring back a metric for the physician executives at the next meeting of the HR committee.
Okay, let me make sure on the annual, go back. That's the quality 30, is that what I'm looking at?
This is the weights of the annual incentive plan for 2020, non-physician executive.
Okay. Okay, okay, those are the weights with the non-physicians?
Correct.
Oh, okay.
Yes, ma'am. This is the
Okay.
weight for the non-physician, for the physician executives.
Okay.
I just want to make sure, so we're tabling both. You've got your population health factors, but what was going to be voted on, both are going to be tabled and brought back.
We just have a viewpoint from this committee that we can roll out at least population health, and then they will officially vote come December meeting or
Okay.
come a January meeting.
So
All right.
we're going to table A and B.
Yeah.
Laura is prepared if you'd like to hear from Laura around the service performance. If not,
I know we've been here a long time. My committee started looking at me funny, so I'm thinking maybe I could get that at,
We started doing that at 5 after.
I know it, but I forgive you for that one. I don't forgive you now, but. How long is it, the presentation, Laura?
Well, it's not long. You actually have resources in your resource tab
Really?
that address the information that you're.
Okay, well, I didn't get a chance to look at that, so why don't we let you,
Walk through it briefly?
right.
Okay, perfect.
You knew she was gonna walk through because she walked all the way to the table.
Oh, thank you very much. Okay, so for those of you who have been part of the board, hello, by the way. If you recall, we actually adjusted our, the way that we actually wrote our goal for last year for the service pillar to the number of dimensions that we moved the national average rate of improvement. And we did that very purposefully because we felt a strong need to ensure that the organization understood all of the elements that our patients, that are important to our patients, and begin working on those regardless of what position they were in. So it was really to validate the right thing at the right time. We still believe that that is the right approach and to still continue to look at the dimensions of care. And additionally, our goal has always been to reach the top quartile of performance. That's what designates an organization as a top performer when it comes to patient experience survey data and the returns of that. And we are still thinking and knowing that that's the right thing to do. And we're now at a place where we can begin to really maintain the areas that have reached that level and really look at how can we get all of our dimensions to that top quartile level of performance. We have sustained 2 of those dimensions over the course of the last 3 years. And this past year, we actually had a very incredible year, and we hit 4 of them, but 2 of them are the ones that we have continued to maintain. And we really believe that now is the maintenance phase of this. So if you look at your materials that you have, the front page just gives a brief overview of the goal itself. And then the additional document, you'll see, let me move here, our inpatient AIP goal. You can take a look at our levels of improvement there. You had asked about percentile ranking. Dorothy, I think you may have asked about that. And it varies by dimension, but there is a chart within your packet that you're looking at that looks like this particular sheet and particular phase, and that shows our FY 17, 18, and 19 results for each of the dimensions of care.
So, top box mean that's the overall ranking? Tell me what
No,
top box
top
means.
box is actually the designation by CMS for the top answer choice. So on most questions, that's all, the answer choices that a patient has is always, usually, sometimes, and never. And top box would represent only those patients who selected always. On the overall rating question, that's actually a number rating system, and that rating, the patient can choose their overall rating of the hospital on a 0 to 10 scale. Top box for that particular question would be any patient who answered a 9 or a 10.
Okay.
And the number that you see there in that top box column are the percentage of patients who actually selected a top box score.
Okay. All right.
Next to that column is the percentile ranking. So the column that shows PR, that's the correlating percentile ranking for the percentage of patients who chose a top box answer.
Okay.
So for instance, on care transitions, 47% of our patients this year rated us top box, and that corresponds to a 19th percentile nationally. There are over 4,000 hospitals that are in this database, so it's every adult acute care hospital in the country. There are over 4,000 of them. And right now, what this is telling us is in the care transitions dimension, 81% of the hospitals are outperforming us.
Okay, so that's
When-
the PR.
That's
the
correct.
percentage, that's the
Percentile ranking.
percentage,
That's
the
correct.
Percentile ranking.
And
okay.
as you work your way down, you'll see that under cleanliness and quietness, just to go through this one more time, I know it's very confusing. 70.9% of our patients selected top box answers for that dimension, and that corresponds to 63rd percentile. And then you'll make your way down. So when you look at communication about meds, 73.8% of our patients selected a top box answer, and that's 87th percentile,
Okay,
meaning the
okay.
higher percentile
Okay.
ranking, the better, obviously.
And so your deal this year is that they will go up what percentage?
We are actually, so last year, if you recall, we worked with national average rate of improvement because that's where we were as far as our numbers were concerned. What we are proposing this year is that we would move the dimensions to the 75th percentile.
So everything would be at the 70, your overall goal is for?
Overall, our goal is that all the dimensions hit the 75th percentile. Statistically speaking, we wouldn't be able to move to that this year, and so what we proposed for you is that we would actually move a threshold of 3 of those dimensions. Again, we've only maintained 2 over the course of the last 3 years, so threshold of 3 is actually an improvement over what we have done in the past. A target of 4 and a stretch of 6 of those dimensions hitting the top quartile, or 75th percentile.
Okay. So when I'm looking at your report here, you have 1, 2, 3, 4 of those are already there.
Four of them are there this year.
4 of them are there.
But if you
this
take a look at them, the only 2 that we've actually been able to maintain for 3 years are communication about medications and discharge information. Those are the only 2 dimensions that year over year for the last 3 years we've been able to maintain that top quartile performance.
But
And one other important point, Dorothy, is there was actually a pain dimension last year, which gave us 10 dimensions of care. CMS has removed that, so we actually only have 9 dimensions of care at this point in time,
all right.
which changes again the threshold, target, and stretch numbers because we have a fewer number of dimensions that we're actually working with.
All right. So let me try to ask it another way.
Okay?
If you are at 87, what do you expect them to go to?
We would expect to maintain performance levels, but what we are suggesting is that we would maintain above the 75th percentile. There is a small variance in number, in percent number, top box number, when you start getting over the 75th percentile. NRC, who is our vendor, that is one of the largest survey vendors in the country, has suggested to us that 75th percentile designates top performance when it comes to patient experience data. So anything above 75th would be in that top performance category. Just to give you a few other statistics regarding our survey, we will get over 150,000 surveys back this year. So this is a large chunk that we're hearing from our patients. And our response rate is between 18 and 30%, which is above the national average for inpatient and outpatient. So,
Okay. So your total number that you now have instead of 10 is 9?
9.
9,
Mhm.
okay.
Yeah, they removed the pain dimension.
All right. I have a question. I just have a comment on your stretch.
Okay.
I need to study your information a little bit so
Okay.
I can really look at it and come back with to ask you some questions about it, because I didn't see it out there.
Okay.
All right. But I would tell you that I would be looking at your stretch to be closer to your 8, because you got 9.
For us, it would be virtually impossible for us. I
I'm
mean,
looking at y'all's
completely
differently.
impossible.
You have on hospital, you only have 4. Your results was 4, right?
Right, so, well, we hit 4 dimensions of care this year in the top quartile. However, again, if you look back at 3 years of historical data, we've only maintained 2 of those dimensions year over year. So we hit 4 this year, but when you look back at historical data, only 2 of those have actually maintained top quartile performance. And what we are suggesting is that our goal needs to be to maintain the top quartile performance by dimension.
So we're at 4, you want to target that for 4. Your threshold says, okay, you know how I feel about the 3s, I'll just leave that alone. But you're saying, my results are 4. I'm really targeting it to stay at 4.
To stay at 4,
And
which
then
would
if
be
we
very
stretch,
difficult.
We would be at 6.
That's correct. And if you look, in order for us to, you know, make the movements, it is very challenging. Again, this database is every single hospital in the country. So it mirrors things like Leapfrog. It mirrors, you know, some of these very, very large databases. It's every hospital in the country.
Okay.
That's an adult hospital. That pediatrics is excluded from this.
All right.
Chair, I have to go.
Okay,
So
I'm sorry.
I will see y'all later. Thank you for
Okay,
the information.
all right. Okay, anybody have any questions? Okay, I'll see you, Amanda, thanks.
Madam Chair, the one thing that we do have to have y'all's consideration on is if we can roll out the LTIP
Yes.
and the annual incentives so that we can often meet the deadlines that you like, and that would be by the end of the year and before Christmas. Not that this is any way related to a Christmas bonus. It is not a Christmas bonus. It is based on incentive, and it's based how employees do it. But we do need, if the committee feels comfortable, to move forward with that. And that's only if y'all feel comfortable.
We do. We do. I do need to do that. Laura, thank you.
You're very welcome.
I'm okay. I just need to look at
Okay.
the outpatient and, their numbers.
So-
And I didn't get a chance to look at that.
And on that, Dorothy, last year, we actually proposed that we move .3 for each of the questions on the outpatient. When we looked at the information this year, we took the average improvement rate for us, and that's what we're proposing for fiscal year '20, just so you know. So it's a little different.
Okay, all right.
It's a harder measure, and so,
Okay.
okay, thank you.
All right, thank you, since nobody had any more questions on that. What I would like to do now is, Peel, yours is just a policy, right? It's no changes on that, right? And so, do anybody want to? Okay. All right, it's been motioned by Dr. P, second by Zim. All in favor signify by saying aye. I need to take a quick break and go to close, and then for about 10 minutes, then we come back for a closed session. We really do need to finish that, I'm sorry.
Do you want your,
Tuition reimbursement, just on that.
That's what was just.
that was just approved, tuition reimbursement was no changes. And again, you want to take up annual incentive
Yeah,
in close? Okay.
and benefits.
And then come back into open?
Okay.
Super.
Oh, I didn't carry it through? All those in favor of the tuition?
You just did tuition reimbursement.
thought I
It was
did.
no
You
policy.
I have a question on that one.
Okay.
Oh, I'm sorry.
For the repayment, it said they have to reimburse back. If it's volunteer, involuntary, within 12 months, what if they got laid off? We can't make them responsible for that tuition. Can we address that?
If you're workforce in transition, that's when we would go on a case-by-case basis.
Okay.
And so workforce in transition, we would then volunteer.
Tell me. Next time we'll have a meeting with me. You okay with it? All right. All those in favor? DT got his question answered. Okay. All right. Sorry, DT. I'm sorry. Okay. Can we reconvene? Can we close out now and for closed session at 1:35? Okay. And we'll
When do
be-
y'all want your committee members coming back, Madam Chair?
Just give me 5 minutes. I
You
gotta
got
take,
it.
yeah,
You
okay.
got it. Just want to make sure that they know when to come back.
From 10 down to 5.
Exactly, that's what I'm trying to do.
Secretary.
Okay.
I'm writing it down.
Writing it
Good.
down?
All right,
It
so
was-
we're approving the payout as to the annual incentive plan?
No, the LTIP,
LTIP.
okay. And
Gotcha.
that was, okay.
Let me make sure I've got this right
Okay.
then.
Run it by me again. We're approving the long-term incentive plan.
We are approving the payout for the long-term incentive plan. That's all we're doing, okay?
For the executives, or that's just for the whole organization?
Well, long-term,
They didn't have any physician executives in it, okay?
exactly.
All right, okay? All right, we got that covered. All those in favor signify by, did you have a question? All those in favor signify by saying aye. All right, all those opposed by nay? Okay.
Will this now go to the board for approval or?
We got 1, 2, 3, 4, 5, 6, 7. We are the
We
HR
are-
joint management and all that, okay? All right?
So does it go on the consent agenda?
It does go on the consent agenda.
Yeah.
Yes.
Okay.
I move that we approve the annual incentive plan with the update that will come for the physician executives.
Okay,
Second.
all right. Motion by Dr. P. Weber. All those in favor signify by saying aye. And those by no, nay. Motion passes. Okay, thank you. Being no further business, we are dismissed. Did you have?